I my topic is on seizure today. Um, so I just thought I'd start with a couple definitions on seizure. Um, Seizures is really any abnormal neurological function that happens from inappropriate electrical activity in the brain. Um, Within seizure, you have epilepsy, which is basically recurrent seizures without any really clear structural or metabolic cause. And you have to have two unprovoked seizures in a time span greater than 24 hours to be called epilepsy. So if you have like a brain tumor and you have seizures, that doesn't count as epilepsy. If you have hypoglycemia and you're having multiple seizures, that's also not not an epileptic seizure because you have to basically have you have to not have a structural or metabolic cause, which I didn't really realize until making this lecture. Another definition is status epilepticus. So it is basically a long seizure lasting more than 5 minutes, or two seizures where you don't have complete neurologic recovery in between the two seizures. So I thought, there are a lot of definitions, but I thought these ones are pretty pertinent to know. Um, I thought I'd also talk about a couple of types of seizures in the beginning. You have generalized and focal seizures. Generalized seizures involve abnormal brain activity, brainwave activity in both cerebral hemispheres, whereas in focal seizures, it's only in one part of the brain. Within generalized seizures, often the most common type is tonic-clonic seizure, where you can see this kind of my little cartoon depiction on the bottom. You start with a tonic. You can have an aura, and then you have a tonic stage where you have this. All of a sudden, you lose consciousness. You have rigidity. You have apnea and cyanosis. And then you have the clonic stage, which is the kind of classic symmetric rhythmic jerking movements of the arms and legs. And then you have the post-ictal state, which is somnolence, fatigue. And this could last, up to an hour. For focal seizures, these can often cause personality changes, hallucinations, altered mental status. You can also have kind of single extremity movement, abnormal movements. Also, the big distinguishing factor between these two categories is that for generalized seizures, you have a loss of consciousness, which is important to remember. And then the other kind of important type of seizure I thought I would mention is absence seizures, much more common in the pediatric population, but this is a abrupt loss of consciousness without a loss of postural tone or a post-ictal state. And this can last from a couple of seconds to minutes as well. But these are harder to find because it just kind of looks like the kid is zoned out or something like that, when in fact they're having a seizure. So when obtaining a history for someone who had a seizure, you want to first make sure, did they actually have a seizure? You want to consider, there are a couple of seizure mimics that you want to consider and try to rule those out when you're obtaining a history. Syncope is the most common seizure mimic, and often hard to distinguish between seizure and syncope. In syncope, you can have hypoxia that can lead to this kind of abnormal jerking movements of the extremities. One way to tell between the two is having a post-ictal state, or having that kind of period where you're really sleepy, and maybe have altered mental status. Is much more likely in the in people who have seizures, up to 5 times more likely in the seizure population than syncope. Also, that how old your patient is. younger than 45 years old, much more likely to be a seizure. Greater than that, in our elderly population, much more likely for those people to have syncope over seizure. You want to look for physical exam findings. The lateral tongue biting that you can see the picture here is a really specific sign for having had a seizure. And interesting enough, incontinence is not helpful at all in delineating the two, as poor specificity and sensitivity for seizures. Other mimics are psychogenic non-epileptic seizures, or PNES, which I'll talk about in a little bit. Movement disorders, where you can have dystonia, myoclonic jerks, and tremors. You can see these in disease processes like Parkinson's disease or cerebral palsy. Reiger's is also a seizure mimic, especially in those patients who are septic, and then dyskinetic reactions from dopamine medications can also cause you to have abnormal rhythmic movements of your extremities. Also, you want to kind of ask the patient and figure out, do they have a history of having seizures? Are they on epileptic medications? And if they have a history of seizures, how is this seizure different from their regular seizures they have? I think this is one of the first delineating things that you want to consider, decision trees, I guess, to consider in someone who's having a seizure is do they have a history of seizures, and is it different? Someone who's coming in for someone with a history of seizure who's coming in for their regular seizure activity that's the same as their previous ones, that patient will get a much smaller workup than the patient who this is their first time seizure, or this is much different kind of seizure that they had than they regularly have. I think those are important things to try to tease out to figure out how much you're going to work up this patient. And so that moving on to differential, and in anyone who's having a seizure, you kind of want to think about what are the causes for them to have a seizure if it's not their like typical epileptic seizure that they have. You want to consider arrhythmia, especially VTAC can mimic, seizures. You want to ask about history of cardiac disease, CHF, things like that. You certainly want to consider tumors, space-occupying lesions in the brain can cause seizures. Do they have a history of having recent significant weight loss? They have a family history of brain cancer. Are they undergoing cancer treatment right now? Some chemotherapy drugs lower seizure thresholds, and so does some radiation therapy too. You want to rule out infection, especially meningitis, encephalitis. Ask about headache, nuchal rigidity, fevers, are things to consider. Interestingly, fevers themselves can lower the seizure threshold, and that's why one of the reasons why you see seizures in febrile infants. But this can also happen in adults, though much less common. You also want to consider electrolyte abnormalities, especially hyponatremia. So you want to make sure the patient, you ask all those questions. Is this a dialysis patient? Do they have diabetes insipidus or any other reason for them to have abnormal electrolytes? You want to consider stroke, do a full neuro exam, make sure they don't have any neuro deficits. Ask if they have a history of stroke. You don't want to miss PRES either, or posterior reversible encephalitis. Something to keep in mind for seizures, though, is that you can have Todd's paralysis, or like this focal neurological deficit in the post-ictal period that can mimic seizure. One way to tell is that, these people, the TOTS paralysis usually results within 30 minutes. So you want to do you want to repeat a neural exam in these patients that you think has a TOTS paralysis over a stroke. This is the TOTS paralysis is one of the most common reasons for people to get stroke workup in the ER, actually. You want to ask about ETOH and drugs. Alcohol withdrawal certainly can cause seizures, and certain drugs, especially the stimulants, amphetamines, cocaine, things like that, can cause you to have a seizure. Also, consider what medications they're on. A lot of medications can lower your seizure threshold. And so you want to ask, have you been started on any new medications, and then look through their med list. Some of the very, very many list of medications that can lower your seizure threshold are fluoroquinolones, penicillins, some cephalosporins, a lot of psych-related medications like SSRIs and TCAs can also decrease your seizure threshold. And then you also want to consider trauma. You don't want to miss an intracranial bleed or something like that. So labs to obtain. You want to get a point of care glucose. You don't want to miss hypoglycemia in these patients. Interestingly, hypoglycemia and hyponatremia is one of the most common reasons for people to have refractory seizures, like seizures that aren't getting better after first, second, or third line agents. So you want to kind of get those levels as soon as you can. Also, don't forget about pregnancy, especially eclampsia in the pregnant patient, because that you treat differently, a little bit differently than you do your epileptic seizures. Obviously, get your electrolyte panel. CK, I'm usually not obtaining in the ER. CK only rises about 50% of the time in people with tonic-clonic seizures. And so it's a poor marker for seizure. I think the one reason to get it is to rule out rhabdomyolysis in someone who you're worried and who's been seizing a long time. In the US, I don't know about Vietnam, we can get anti-epileptic drug levels, especially for valproic acid, phenobarbital, phenytoin, and carbamazepine. And so if your patient is on one of those medications and you think this is that they're being underdosed, is something that you can get. Consider getting a urine and serum tox level on people you think you're worried that are intoxicated. And then lactate. I think lactate can be helpful in identifying seizure. In up to 90% of people with tonic-clonic seizures, these people will have elevated lactate. It's just not very specific test for seizure. If you do get a lactate, though, it usually returns to baseline in 1 to 2 hours in someone who is otherwise healthy and can clear lactates. So it's worth repeating if you get an elevated lactate and the patient's still going to be in the ER. LP, you want to consider getting in anyone who you think has an infection, especially meningitis. Also important to get in someone who you're worried who has hydrocephalus, and in patients that are immunocompromised and just can't mount an infectious response or inflammatory response. You want to consider doing LP. And then moving on to imaging. I don't think that we need a CT scan all patients that have seizures, but you definitely, I think, want to, for the most part, get a CT scan for first-time seizures, or if you're worried about any structural lesions or intracranial hemorrhage, you want to get a CT scan if you think the patient had a significant head trauma causing their seizure. Also, if you're worried that this patient just sees so hard that they hit their head really hard, you want to get a CT scan for those people. And then you can consider getting even further advanced imaging like MRI for people that you think had a stroke. Moving on to physical exam, I think most of us have probably seen seizure. More often than not, people are being brought to the ER for tonic-clonic seizures. I think just because those are more common and also much more impressive to bystanders. So you definitely want to look for those. Look for the tongue biting and plus minus incontinence. In the patient who's actively seizing, they will often have hypertension, tachycardia just from the kind of overwhelming brain wave activity can cause this sympathetic surge. But you also want to look for the more subtle signs of someone having a seizure. You want to look for twitching, automatisms, kind of repetitive, non-purposeful movements. People can have kind of picking movements, lip smacking, verbal sounds, and these are often missed in the ER as seizures, whereas they should be treated as seizures if you're able to identify them. Interestingly, up to 14% of patients who get treated in the ER for a seizure have these kind of subtle findings afterwards that are missed in the ER and only found as an inpatient when EEG is placed. So even if the patient came in with full-blown tonic-clonic movements, after you give the benzodiazepine and their movements get better, you still want to kind of do a full exam and observe them to make sure that you're not missing any of these kind of more subtle signs that would prompt you to continue treating the patient as having continued seizures. And then you also consider negative symptoms can be found in seizures as well, with amnesia, aphasia, mutism, and staring. Moving on to treatments. Historically, I think seizures have been undertreated with benzodiazepines. First line agent is going to be benzos. And you want to give them enough big enough dose and give it to them as quickly as possible in someone who's in status or actively seizing. You can give benzodiazepines IV, intravenously, intramuscularly, or intranasally. I use midazolam for the most part if my patient doesn't have an IV and I want to give an intramuscular dose, just because it's the quickest onset intramuscularly. But any of these benzodiazepines will work if you have an IV. And you can give midazolam intranasal as well. I usually give up 2 or 3 doses. I'll redose the patient once or twice on the benzodiazepines before moving on to a second line agent. So second line agents are fosphenytoin, phenytoin, levetiracetam, and valproic acid. Fosphenytoin is basically a phenytoin prodrug that's diluted in water. And I think it has a more favorable side effect profile, and you can infuse it faster is the kind of benefit and the difference between the two. The benefits of these second line agents is that they all increase your seizure. They treat seizures, and they're less sedating and cause less hypotension than the third line agents, which are ketamine, lacosamide, and phenobarbital. And at this point, if you're moving on to third line agents, you really should be considering intubation for these patients, because these can significantly sedate someone, and someone who's already having a seizure and you're worried has airway compromise. You want to be thinking about intubation sooner rather than later. And then fourth line agent is the anesthetic or sedative group, which is midazolam, propofol, phenobarbital, and thiopental. And at this point, you're definitely intubating this patient. You also, if you're reaching for these, definitely consider that these can cause profound hypotension, so you want push those pressors in the room readily available. So intubation, not all patients with status epilepticus need to be intubated, but you certainly want to think about this soon, as soon as or sooner rather than later. I would think about this when you're giving your first dose of benzodiazepines, just because you don't want to be scrambling to get all your intubation supplies and medications when you're on second or third line agent and the patient's airway is getting more compromised and they're now hypotensive. This isn't the time to be trying to scramble to find these things. So you want to get all your equipment and people ready as soon as you can, in anticipation of having to go through this kind of algorithm. Induction agents, you can do midazolam, propofol, or ketamine. Midazolam is also obviously a benzodiazepine, so we'll treat seizure that way. Propofol is a NMDA or a GABA antagonist, and then ketamine works on the NMDA receptors, and so that's how they treat seizures. And then for paralytic, the debate between rocuronium and succinylcholine, they both have their downsides. You definitely run a risk of hyperkalemia in a depolarizing agent like succinylcholine. And so that's something to consider in someone with prolonged seizure and you're worried about rhabdo. But you also have to weigh that against rocuronium, where you can have a prolonged paralytic effect and thus can make it impossible for you to determine if the patient, you adequately give them enough anti-epileptic to stop their seizures or abnormal brainwave activity if that patient is paralyzed. One trick for this is you can put a tourniquet on one of the extremities that's having seizure movements before giving the rocuronium to see if you're adequately you've adequately treated their seizure. You can also give Sugamidex, which I'm not sure if that's available to you guys, to reverse the rocuronium. And then you can also get an EEG once they're intubated, if you're unsure if they're continuing to have epileptiform activity in the brain. Obviously, if you're intubating someone, these people need to be admitted to an ICU. But I think this is a good place to kind of also talk about which patients can you discharge from the ED, and do you need to call neurology for a patient who had a seizure that's now treated and back to their baseline. For the most part, someone who has a known seizure history that came in with their exact same kind of seizure activity that they usually do, that patient does not need you to call neurology and can usually be discharged. If you think that they're having more frequent seizures and maybe needs a medication change, then that's a reason to talk to neurology. But for the most part, these people can go home. First-time seizures, these people, for the most part, don't need to be started on an anti-epileptic drug, but do need to follow up with neurology as an outpatient. But I think when they're coming back with their second or third seizure, these patients probably warrant being started on an anti-epileptic out of the ER. Also, when you discharge these patients, you want to counsel them on avoiding any activity that puts them at risk if they have a seizure, like swimming, driving, and things like that. In California, I think I think ER doctors are mandatory reporters to the DMV for people who have seizures and they get their license taken away. Yeah. And then I thought I'd just kind of talk about some special populations and considerations. Um, the pregnant patient, you'll always want to think about eclampsia, which is kind of development of seizure in a pregnant patient with preeclampsia. And just to remind you, preeclampsia is basically hypertension in a pregnant patient greater than 20 weeks gestation, with a systolic blood pressure greater than 140 or a diastolic greater than 90. Um, you treat seizure, or you treat eclampsia a little bit differently than just your regular seizure, in that you give them magnesium, a big dose, 6 grams IV, followed by an IV drip. If the magnesium isn't working, you can certainly give benzodiazepines, and then you also want to remember to give them control their blood pressure um, as well. Some another just consideration for a pregnant patient is cerebral venous sinus thromboses. Just because they're a higher risk because they're a little bit more coagulopathic. And then pediatric patients also, for the most part, we treat ped seizures similarly to adult seizures with our medications. Kids do have kind of some unique things about them. They have unique mimics of seizure, including breath holding spell and bruit or brief resolved unexplained event. Both, kind of causes hypoxic period that can cause these kids to have abnormal jerking movements. So you certainly want to ask the parents or whoever brings them in, what they saw, and try to tease those things out. Also, kids with cerebral palsy will have kind of more hypertonicity that can be mistaken as seizure. Also, for kids, they have, kids grow and gain weight for the most part, much faster than adults do, which means they can outgrow their for kids who have seizures and that are on a seizure medication, they can outgrow their medication doses quickly and can be underdosed. So that's just something to consider. And then for kids who are actually having a seizure, you want to consider their age range. And the neonatal kids less than 1 month old, seizures are more subtle and have worse prognoses. You also want to consider these kids are much higher risk of infection, like bacterial meningitis. You also want to remember viral encephalitis with herpes as well. These kids are also at risk of having withdrawal from substances due to maternal drug abuse. And then for infants 1 month to 6 months, you want to ask about their diet. Overdilute formula or excess water can easily cause hypoglycemia and hyponatremia, which can cause seizure. So something to consider. And then the most common thing I think we see for seizures in kids is the febrile seizure. A child with a simple febrile seizure can, for the most part, be observed in the ER and then discharged home. But to qualify as a simple febrile seizure, you have to meet all 4 criteria, which is duration less than 15 minutes, fever of 38 degrees or higher, ages 6 months to 5 years old, and then only 1 seizure in a 24-hour period. So if they meet all 4 criteria, they qualify as a simple febrile seizure, and you don't have to do any imaging or talk to a neurologist, and just observe them for a little bit in the ER and discharge them home. If they don't meet this criteria, or if the kid appears ill, you want to do a full workup, including an infectious rule out with CBC, UA, with cultures, blood cultures, chest X-ray, and also consider doing a lumbar puncture as well. And you likely want to start antibiotics as soon as you can for these kids too. And then I just thought I'd include some pediatric benzodiazepine doses at the bottom here. It's basically just 0.1 milligrams per kilogram for most of the benzodiazepines. And then the last kind of special category I thought I'd talk about is the psychogenic non-epileptic seizures. I think this is psychogenic non-epileptic seizures, or PNES, is basically seizure-like activity without any abnormal brainwave activity on EEG. This can be really hard to diagnose in the ED and distinguish between an epileptic and non-epileptic seizure. PNES is often associated with mental health illness like depression, PTSD, and personality disorders. For the most part, I think you want to treat these patients if you're unsure as seizures. But when you're, talking about intubation, we definitely want to avoid unnecessarily intubating someone and committing them to ICU stay if possible. And so there are just a couple things, clues for PNES, clues to point you towards PNES over epileptic seizure. For PNES, these people can have preserved consciousness and memory recall. And so, someone who's kind of thrashing around but can follow commands or recalls the event, that person more likely than not has PNES. If you can remember, a generalized tonic-clonic seizure, by definition, you have to have loss of consciousness, which is kind of a distinguishing feature of it. For PNES, people can have purposeful movements. They can have a back arching or pelvic thrusting, which is classic for PNES. Also, these patients can have their eyes tightly shut, which is abnormal for an epileptic seizure. You have to actively try to engage those muscles to close your eyes, which is not commonly seen in seizure. And then some other clues are head rolling, crying, inability to protect themselves from noxious stimuli. PNES doesn't have a postictal period and often doesn't have an elevated lactate unless they're thrashing around very, very aggressively. And so I think that's really all I have for the lecture portion of this. Does anyone have any questions for me before we move on to doing a quick case?
Do you in Vietnam take away people's driver's license or driving abilities when they are diagnosed with seizures? Can anyone answer that for me? I'm just curious.
I don't think so. I don't think in Vietnam we don't take away the driving license of seizures patients.
Okay. Yeah. Okay.
All right. I guess we will move on to doing a case. Okay. How should I do this again? Scott, I already forgot. Should I just call on people, or do people want to volunteer? Should we do this as a group, or I don't know. I forget.
I think it's best as a group usually, as long as people are chiming in and participating.
Okay, sounds good.
And feel free to use the text box too. If you're not, in a quiet enough place to talk, you can put in the text box.
Yes, you can certainly do that. Okay. And please participate, because this is my first time doing a lecture and I don't want to feel lonely all by myself. Okay. All right. So your case, you have a 56-year-old male who's presenting with a seizure. EMS report, the ambulance people, basically they tell you that they got called by the patient's wife for having a generalized tonic-clonic seizure activity. And then when the ambulance people got there, the patient was still having a seizure, so they gave them 2 milligrams of lorazepam intramuscularly, which didn't help the patient at all. And you have your vitals here: heart rate of 127, blood pressure of 175/93, respiratory rate of 18, satting 96% on room air, temperature 36, and weight of 100 kilograms. Yeah. I guess when you walk into the room, you see the patient is still having a seizure activity and is unresponsive. What are some things you want to know right now? And this is not a hard case. This is not. I'm not here. There are no tricks here. This is just just a simple case of seizure that we can go through.
Just want to ask about the history, the first time of the seizure, many times.
Yeah.
And
the patient does not have a history of seizures, so this is their first seizure. Actually, no, I'm sorry. The patient does have a history of seizure, and they are on an anti-epileptic medication. Give me 1 second. They're on levetiracetam 1,000 milligrams twice a day.
and ask about a quick question about the recent day the patient quit the medication.
Yeah. So the patient has been taking his medication every day, but he's been having nausea and vomiting for the last 4 days, nausea, vomiting, and diarrhea for the last 4 days. So hasn't necessarily, he's thrown up some of his medications in the last 4 days. But this is a patient who's like actively, you walk in the room and he's still seizing. So what are some things you want to do and want to know right off the bat in the beginning, and someone who's still, having this seizure?
This means now the patient still a seizure?
Correct, yeah.
I think the first important, we need to control the seizure. Maybe repeat the one dose of the lorazepam, or give another midazolam.
Sure, yeah. So let's say you gave 5 milligrams of midazolam, and they have no improvement in their seizure. They're like drooling from their mouth a little bit, but they're able to breathe. They're kind of having this snoring, breathing. They're going, and then they're still seizing. Basically, what do you want to do next?
Another dose of the midazolam.
Good. Yeah. So you give another dose of midazolam and the patient stops having a seizure. So now that the patient has stopped having a seizure, you're kind of able to talk to his wife, who's there as well. And she tells you, he hasn't been feeling well for the past couple of days and has been vomiting and having diarrhea. He was watching TV today when he started having the seizure, and that's when the wife called the ambulance. And so by the time that the ambulance had gotten there, he'd been seizing for 10 minutes. And then it was like a 5-minute drive from his house to the hospital where you are. What other questions do you want to ask? any physical exam things you want to do, and labs you want to order. Anyone else?
Maybe I want to order a quick glucose and as well as the electrolyte panel.
Good. Yeah. I will give you his labs. You know, for the most part, his labs look okay, except for the creatinine of 1.6. But no significant electrolyte problems. Their glucose is normal.
I want to check if he has any neuro deficiencies to rule out stroke.
Awesome. So he's now post-ictal, so he's sleepy. He's GCS 12. He localizes to pain. He opens his eyes when you to voice, but he's a little bit confused. He's alert. He knows what his name is and he knows what date it is, but he can't remember any of the events of the seizure and doesn't know where he is. He doesn't have any cranial nerve deficits, and he's moving all his arms and legs, and he doesn't have any weakness or numbness. At this point, what do you want to do with this patient? Do you want to get further testing? Do you want to bring him into the hospital? Do you want to talk to a specialist, or do you want to send him home?
Usually, I want to take a CT scan first.
Sure.
And then I will consult with the neurology department.
Okay. His CT scan. Oh, I did not include here, but his CT scan looks fine. And then when you talk to neurology, they recommend doing an EEG and admitting him to the neurology team. And that is the end of your case. Good job, guys. Thanks for participating. So this is just a case of a seizure in the setting of the patient, you know, having probably a gastroenteritis with the nausea and vomiting and not being able to take his regular medications. Because he had status epilepticus, you know, he had a seizure longer than 5 minutes. You want to bring this person into the hospital to make sure that he has a prolonged observation, and they can restart his anti-epileptic medications. What else? I think we can talk a little bit about how to manage this patient's airway when he initially came in. Someone who's actively seizing, you're certainly worried that they're going to aspirate. They're going to, you know, aspirate on their own saliva or throw up and aspirate that. So you want to position them on their side so they can protect their airway. You can do jaw thrust, put in a nasopharyngeal airway, and place a nasal cannula or non-rebreather for oxygenation. And someone who you're worried is throwing up or is going to throw up, I would probably not do the non-rebreather and maybe do high flow nasal cannula or something like that. And then if they aren't protecting their airway, you obviously want to move towards intubation. Let's see. Otherwise, differential for refractory seizure is hypoglycemia, hyponatremia, hypocalcemia, eclampsia, and isoniazid overdose. So really, you really want to, in patients that they're not getting better, you really want to think about electrolytes and glucose, which you guys did. And then Obviously, this patient isn't female or pregnant, but eclampsia and then isoniazid overdose, which I've not seen once. I think that's about all I have. Thank you guys for listening to me. Does anyone have any other questions or any other comments that they want to make? Okay. Jane, I got nothing else. Do you have anything else for them?
I left some comments on the side.
Oh, I'm sorry.
For people to read. You don't have to read it. Just for some tips and tricks for people in the ER, right? The first thing to remember is to give them medications early and at the right dose. The pitfall is we give it too late. And sometimes I was saying for some of these questionable seizures, you shouldn't have a focal seizure that happens on both sides, because that crosses both sides of the brain. And if they maintain consciousness and are talking to you, that's not a true seizure, right? Or if someone's like shaking and you're like, oh, you're okay, please grab my hand, and they're able to stop and grab your hand, that's also not a seizure. And then I put a second a comment on the ESET trial, which tested the three different second line agents and kind of to see which one is better. They all work as second line agents if you give them the correct dose. We just prefer, or at least I prefer Keppra because there are less side effects compared to the other two second line medications. But obviously, it depends on what medications you have access to. Any other comments before we meet again next week?
Thank you. Maybe actually.
Yeah, that's the plan. Yeah. And maybe Dr. Asao can come along with us. And Scott. Maybe Shirley. We shall see. Vera. Everyone. Because we love you.